Hello, everyone. So now we're going to shift gears and talk about the role of the first trimester ultrasound in the evaluation of multiple pregnancies. I have no disclosures. By the end of this lecture, you should be able to explain how to determine chorionicity in twins, how to screen for aneuploidy in twins, how to screen for malformations in twins, and recognize the various complications. So looking at the USA data from the CDC, you can see that the rate and number of twin births in the US has been on a steady decline. This is because of limiting the number of embryo transfers. And this is particularly true in 2020, where we saw the nadir, probably as a result of COVID and limiting all assisted reproductive procedures. Embryologically, just to review, we have two main subgroups of twins. We have the dizygotic twins that constitute 70% of all twins, and these start with two oocytes that are fertilized separately and result in dichorionic diamniotic twins. Now, almost 30% of the remaining twins are monozygotic, where it is one fertilized zygote that's going to split at different points in time, and depending on how early or late the split is, will result in either di-di twins, mono-di twins, or mono-mono and conjoined twins. So let's now look at the monozygotic twins that are the 30%. Of those, a quarter are going to be di-di, and 3/4 mono-di, and then less than 1% will be mono-mono or conjoined twins. And how this is determined is at what stage the cleavage occurs. The earlier the cleavage, the more distinct the twinning is going to be. So if you have cleavage at the morula stage, days 1 to 3, you will going to have di-di twins. And if this cleavage is day 4 to 8, at the blastocyst stage, you're going to get the mono-di twins. And if this is between days 8 to 13, in an implanted blastocyst, you'll get the mono-mono twins. And finally, anything beyond 13 days with a formed embryonic disc, you will get the conjoined twins. So the role of ultrasound pertains to dating, labeling, establishing chorionicity, screening for aneuploidy, malformations, and complications. So we'll start with dating, just as we talked about in the first trimester. Depending on when you are, you're either going to use CRL or biometry. But when you have multiples and you have more than one CRL, always use your largest CRL. And if this were the result of assisted reproduction, use the IVF established dating. So here are two twins. If they did not have any date, even though they only differ by 3 days, I would use the larger twin, which is an 11-week, 1-day size. Labeling is not as easy as one would think. There are different ways to do it, whether in terms of position, cord insertion into the placenta, sex, and so on. But let us look. To simplify, they can either be on the maternal right and left, or superior inferior. And even the ones that are on the maternal right and left, the presenting twin may not always be the same one. So it's true that the amnion, the amnion here is to the right of the cervix, meaning the left fetus has the first access. However, you can have folding of the membrane, which makes this much more complicated. And so you would have to resort to more than one way to establish which twin is which. So in this case, you clearly can see a superior and an inferior twin. And here with these triplets, you have an inferior twin, and then the two that are superior, one is maternal left and one is on the maternal right. Using the placenta and cord insertion into the placenta is very helpful. So this was a case of monochorionic diamniotic twins with a posterior placenta. And you can see that the twin B has a cord insertion superior on the placenta versus twin A that had a more inferior, almost marginal insertion. And so cord insertion can be very helpful. Chorionicity can be well established in the first trimester, much better than at any other point in gestation, and it's not always as clear as we see in this schematic here. So some key features as you sweep through, you see with these two twins, you don't see any big separation between the two, yet you see two distinct yolk sacs. Same here, one yolk sac, and there is another yolk sac right there. And so when you don't see clear demarcation between the two, and less than 8 weeks, you can have a very thin intertwin membrane. You use the number of yolk sacs for the number of amnions. So rely on the yolk sacs as the number of amnions. And in monodi twins, the membrane can be easily missed less than 8 weeks. And so you may need to do transvaginal and use the number of yolk sacs. Other things to look at. So if you are scrolling through the image on top, you see that there is very clear separation, and you can have two placental masses and a lambda sign that helps you tell that these are di-di, versus the twins inferiorly where you barely see a separation. And if I were to look, you would tell me, is this a lambda sign here? And no, this is not a lambda sign contrasted to the image on top where you see thickness because of the chorionic plates coming together versus here. So this is a pseudo lambda sign. This is in fact a T sign in monochorionic diamniotic twins. And here you can see very clear demarcation again between the two, very thick separation between the two in a di-di gestation. We talked about the number of placental masses and fetal sex, which may not be apparent early on, as ways to help us as well. So to determine chorionicity can be as high as 100%. Let's look at the images on the left. You will see that there is a very thin intertwin membrane. There's no clear lambda sign. Contrast here with lambda signs on either side here and here. So the ones on the left are monodi. The ones on the right are di-di twins. How accurate are we? You can see that overall sensitivity in the first trimester is similar to the second, but we are more specific and a much higher positive and negative predictive values. And looking at the various markers with respect to accuracy, you see that we can reach 100% accuracy using the lambda sign and gestational sac number, and the lowest accuracy is just relying on membrane thickness alone. Why is that? Because depending on how high your gain is, your angle of insonation, these may all factor in and impact membrane thickness. Looking here, you can see clearly that these are dichorionic diamniotic twins. So are these with a clear lambda sign. And as we scroll here as well, we have very clear demarcation between these two sets of twins, the images on the left and the right as well. And this from the bladder, as we sweep up, we can see 1 and 2 with a thick lambda sign between them, dichorionic diamniotic. And as we sweep through here as well, again, you see very thick separation, di-di, and here as well, even though there is a much smaller twin that does not seem to be the same size. And here, as we sweep through, you see 2 with a very thick demarcation. Don't let your guard down. Continue your sweep because there's a third one. So this was trichorionic triamniotic gestation. And here again, as you sweep through, 1, 2, and there is 3. And so when you do have triplets, you can have lambda signs between all of them to ascertain that they are triplets. Here is another set, and here is a more recent set at an earlier point in gestation. Again, clearly see the differentiation and the lambdas between all 3 of them. And this was a set of quadruplets, very difficult to see, very thin separation. So these did contain a monochorionic set. And here, as you look at these 2, you can see 2 yolk sacs, you can see the amnions, but not much of a separation otherwise. And so these are monochorionic diamniotic twins. And here, as you look at these two, right about here, the heads are so close to each other, you start to wonder, do I have monoamniotic twins? And then you have to look very carefully, and you will start to see a little bit of a membrane here and here. As we continue on down, there it is. So these are, in fact, diamniotic, but they certainly are monochorionic. And what about here? You can see very thin. This is a T sign, a very thin membrane there. These are mono. And here again, this is another set of twins. As you see them through gestation, this is earlier than the images here. But again, it was a very thin intertwin membrane. It was difficult to ascertain that they were diamniotic, but they were in fact diamniotic monochorionic twins. And here you have another set that is in very close proximity as you look through, but there is a very thin membrane. And as you slow it down, you will see, let me try to show where that membrane is. This was one of the ones we had difficulty stating, but there is membrane right here around this one. And you can see a hint of it right here as well. And here as well. So there really was a very thin membrane. I think she was referred to us because it was felt that she was a monoamniotic, monochorionic twin gestation. And here are examples. These are all, this is a case that actually was perplexing later on, showing the importance of establishing chorionicity early on. Looking at these twins in the first trimester, it was clear that they are di twins. But when she came back at 20 weeks, there was poly. There's a very thin membrane. We could not see a lambda sign. And without going back, and finding, see, this was very close to one of the twins here, almost like a TTS picture, but we could see bladder and stomach on both without going back to the first trimester to be sure that they were indeed di. It was hard to decide what was going on in this case. And so this was going back again, and those were her images at 12 weeks, and you can see the small lambda sign there. Here's another set that as you sweep through, what you see is you see two that are so close to each other without color. As you go back and look at this cord, you will see that it almost seems as if you have entangled cords right about here. These were mono, and here they are again. Look at how close they are together. And look at their cord. So the cord was already entangled at the time of their first trimester scan. And here's another set. And again, in very close proximity, you cannot really see a dividing membrane, and you see where the cords are inserting, they are really entangled together. And this was another case from a colleague of mine in Lebanon, just showing very clearly the entangled cord of mono twins. And here is another case looking very early on. You see some tissue bilaterally with a central beating structure. Those were conjoined twins. And here it is with color again. And here was another set of twins at 6 weeks, 6 days. And the latest that we've had a few years back was this patient with a prior history of C-section who came in with pain and bleeding, clearly had a gestational sac, viable fetus, but then this is the uterus sagittally on transvaginal scan, and here is her scar, and you can see that there is another pregnancy in the niche. So this was a heterotopic gestation with an intrauterine and a C-section scar pregnancy. And here it is again on 2D and using 3D reconstruction. So what about screening for aneuploidy? Screening for aneuploidy is as we do with singletons, and we did talk about this, but what are some important things is you use the NT, and for some reason, trisomy 21 is 3 times less likely in monochorionic twins versus singletons. Using the combined test, which in the era of NIPS is not something we're using as much, it does have an 85% sensitivity for a false positive rate of nearly 10%. NIPS is 98% sensitive with a false positive rate of 0.05 for trisomy 21, and I'll show some data for other types of aneuploidy. However, test failure is 3.3 times higher in twins, dichorionics versus singletons. So looking at some of the meta-analyses we have, here is one from Nikolaidis' group in the White Journal in 2019, where they found, using their pooled analysis, 98.2% detection rate of trisomy 21 for a false positive rate of 0.05%. And then a more recent study that was also from Nikolaidis' group, they looked at trisomy 21, 13, and 18, and they had a 99%, this was on 7,500 patients, 99% detection for trisomy 21. They had 92.8% for trisomy 18, and they had 94.7% for trisomy 13. And so this is why it varies. It is still the most sensitive for 21, but it's pretty reliable if you do get a result for both 13 and 18. What about screening for malformations? Keep in mind that the rates of pregnancy complications are higher in twins in general and anomalies in general, and of course, more so in dichorionic, more so in monochorionic versus dichorionic pregnancies. So if we look at the rates of miscarriage, higher in the monochorionics. If we look at fetal anomalies, much higher in the monochorionics. And this is why it's important to perform an anatomic assessment, as we've already spoken about today. So you do your CRLs, you do your NTs, you're going to do your full assessment, inclusive of the heart, and you can pick up a lot of abnormalities. Okay, the mid-sagittal plane, I covered this in the first presentation. I'm not going to go through it again, but again, this has many hidden markers to rule out various abnormalities. And I have to highlight the importance of a transverse sweep of the entire fetus to really look at so many structures within a few seconds. So this is a 12-second clip, a very old clip, if I may say, maybe 10 years old. You start with the butterfly, which helps you rule out holoprosencephaly. As you continue on down, you're going to get to your orbits. So here are my orbits, and here are my lenses. And as I continue on down, you're going to get to your retronasal triangle. Here are my nasal bones, my frontal processes of the maxilla. And I don't see my primary palate very clearly, but here it is. So part of the retronasal triangle. Then I see my mandibular gap. And then as I continue on down, I'm going to get into my 4-chamber view. And here is my my septum there, aorta and cross section. Continuing on down, here is my stomach. And continuing on down, I barely can make up a little bit of the left kidney there. And then continuing on down, here is my cord insertion. And continuing on down, here is a little bit of my bladder and the extremities. So in 12 seconds, you're going to be able to see so many of the key anatomic structures in the fetus. And here are just various transverse sweeps. I'm not going to slow all of them. Twin A and twin B, and with that you can really do a very quick screening for all major abnormalities. And here's another set of twins. You can already note a discrepancy in the size between the two, and this helps you predict complications. So for complications, many complications in twins. First, maternal. We know we have a higher risk of preterm labor and PPROM, more preeclampsia, placental abnormalities, complications related to infections such as pyelo, and of course, postpartum hemorrhage. But in terms of the fetus, we know we have more growth abnormalities, congenital malformations, NICU admissions, cerebral palsy and perinatal death, and of course the complications of monochorionicity such as TT, TS, TAPC, and TRAP. So let's look at preterm births in the US. This is data from 2018. And looking at all births, we have about 10% that are preterm out of 3.7 million births. Now, in twins, the rate is 6 times as high, so it is 60.32. And some of the complications in twins to keep in mind, 1 in 1,000 are monochorionic of all pregnancies. Of those, 15% will develop TTTS, 3 to 5% will develop TAPC, and 1 in 4 will have discordance, including selective fetal growth restriction. 1% will be monoamniotic and at risk for cord entanglement. And if you look at deaths in twins as well and stillbirths, you will see that in singletons, it's been quite steady, but in twins, it started much higher. We've kind of stabilized a little bit, but it's still much higher than in singleton. Vanishing twins do occur before 12 weeks in about 36% of twins and more than half of triplets. And there's something called the fetus peperaceous after 12 weeks. The thing you have to keep in mind is this may have an impact on your NIPS interpretation, but they tend to be resorbed. And what is the effect of it on pregnancy outcome is that when you have 3 or more gestational stacks, more than 50% of them will have spontaneous reduction before 12 weeks. However, the surviving fetus will weigh less, is at a higher risk for preterm birth versus those that have not been reduced. Now, what about the particular things of the first trimester that may alert us to predict complications? And things as simple as your NT and CRL do play a significant role. So if you have an NT on one of the twins that is more than the 99th centile, or a 20% discordance between the two, or a CRL discordance of more than 15%, then almost half of these may develop early in utero fetal demise, TTTS, or selective fetal growth restriction. So be very mindful that if you have NT discrepancies or size discrepancies, to be very watchful of these twins. Now, in trying to look at nuchal translucency for TTTS, this was a report from Kagan in the White Journal in 2007 as to the importance of NT of more discordance of more than 20%. And again, from that same study, looking at outcome, when you have discordance in NT or in CRL, there's a statistically significant difference in severe TTTS or early fetal demise. So this is very important to keep in mind as you are getting different measurements on these twins. Now, SMFM has its guideline for twin-to-twin transfusion syndrome, and they use an NT more than the 90th percentile, not 99, and a discordance of more than 20% between the twins, and which is what is used, what Kagan alluded to as well. And according to the SMFM, their management in the first trimester is you confirm monochorionicity and you do your NT screening, you bring them back at 16, you check your maximal vertical pocket, and if it's normal, you continue to do surveillance every 2 weeks. If it is less than 2 centimeters in one, and then you will make, or more than 8 in the other, you do diagnose TTTS and manage them accordingly. So here are 2 twins that were discordant for CRL and NT at 11 weeks and 2 days. And these did have a very poor outcome. So as you can see, the abdominal circumferences are quite different. Look at the NT of this first one, it was thick. The second one, you don't see it very well in this clip, but it was normal. And here is another discordant for CRL and NT. You can see these have an entangled cord. Those were mono-mono. and they did have significant complications later on in pregnancy. And here is another set at 17 weeks, 3 days, and see the difference in the size of the head and the size of the abdomen at 17 weeks, 3 days. So you had selective fetal growth restriction. Now, here was another set of twins on a high BMI patient, and it's very hard to see, but what this area is really the fetal head. The arrow is on the fetal head. The lower twin was normal, but the top twin, we could not see the cranium. And in this case, this was selective anomaly of acrania on one of the twins. And here you can see one twin, and this was the normal twin on the left versus the twin with acrania on the right, and you can see it a bit clearer now. You see the orbits, and you see the absence of the cranium and the shape of the protruding brain matter. Here were those quadruplets that I showed earlier on, and one of them really had a very thick NT, as you can see here. The other three were perfectly normal, so you can have discordance there. Now, ISWAG has its twin guideline, and it does differ from the SMFM in terms of how we follow up and how frequently we assess monochorionic twins. But I will start with the dichorionic twins, and what they recommend is these are seen and labeled at 11 to 14 weeks. This is dichorionic. Then you don't need to bring them till 20 to 22, and you follow them every 4 weeks. However, when you have monochorionic twins, they are followed from 16 weeks on every 2 weeks. And you're going to initially start growth in maximal vertical pockets. Then you do your detailed anatomy, cervical length, and Dopplers as well, starting at 20 weeks, and you follow them every 2 weeks. I'm not going to go much into the Quintero staging, but this is still the main type of staging that we use, stages 1 through 5, starting with Ollie-Poly in the twins, and then changes where you may not see the bladder, having abnormalities in the cord, having high drops, and eventually losing one or both fetuses. And here is a trap where you can see an acardiac twin right here. Always these bring to mind, is this an amniotic, is it a body wall defect? Is it related to amniotic band? But usually you can see it in twins. The other one is just a very abnormal looking twin. And conjoined twins occur roughly in 1 in 100,000 births, many different types. The most common is the thoracopagus joined at the chest that occurs in about 75%. There have been many conjoined twins that have survived. If you look, some of the earliest twins that have been reported on are the Bunker twins, and there have been many others over the years, conjoined at different of different types, and they have had some of them very long and fulfilling lives. Here is another case that presented with a missed AB very early on, less than 10 weeks, and there was a mass noted next to the head of the baby, and using 3D ultrasound, we were able to show that these were in fact conjoined twins, and so these would be more challenging to pick up. And other 2 sets, these were very early on at about 7 weeks. This was a beautiful example from Professor Abu Hamad, where you can see the thick nuchal and the vascularity between them. And this was a more recent case that we had at full term, conjoined twins, thoracopagus with heart that was common between the 2. So to conclude, always remember to ascertain the number of fetuses, date them properly, label them, establish chorionicity, then do your NT because it plays a role in prediction for TTS, do your detailed anatomy and your serial growths on them. And ultrasound plays a critical role in all of these aspects to optimize their attention. There's a lot more than just the CRL. And I thank you for your attention.